Good morning, everybody. Once again, my task is that of focusing on treatment. Firstly, before we talk about drugs and possible treatments, I would like to draw your attention to the following aspect. We need to understand what is to be treated, firstly. Obviously, we're treating seizures. Our objective is that of obtaining a remission of seizures. However, in the population that we studied, we have a very considerable variability in terms of seizure frequencies. We have about 20% of patients who are seizure-free for at least 2 years. There are many patients who either spontaneously or thanks to the use of drugs are seizure-free. The other patients are as follows. About 80% of patients have annual or less frequent seizures or clusters, which goes to, say, 2 or 3 a year. And then 20% of patients are more complex and they have regular, either monthly or weekly seizures. And all of this can be seen with an average of 2 drugs each, with a variability of between 1 and 4. Another consideration that has to be made is the following. Seizure frequency changes with age. There is a more active pre-pubertal stage, a post-pubertal stage, during which seizures decrease. So if we are to evaluate the frequency of seizures and the effectiveness of drugs, we have to differentiate patients on the basis of their age as well. So, what we have to bear in mind is that if we use a drug at a certain point in time, and this is something that we have to be aware of because errors can occur, and as we know, there is a variability in seizure frequency. Epilepsy is a chronic disease characterized by periods with fewer seizures and periods with more frequent seizures. So if we try and test a drug at a good time, then this drug is considered as being effective. If, on the other hand, we test a drug or we give a patient a drug during a period characterized by a worsening of seizures, that drug is considered as a drug with limited effectiveness. So we have to bear in mind the time when a drug is introduced in treatment to determine whether or not we can really talk about effectiveness of drugs. Moving on to available studies, we have a number of retrospective studies. This one is on the effectiveness of anti-epileptic drugs. It is a multicentric European study, 58 female patients aged between 2 and 27. And this, of course, is very important when it comes to evaluating data. Here we see the most commonly used drugs: carbamazepine, clobazam, levetiracetam, LTG, phenobarbital, TPM, and VPA. So there's quite a long list, as you can see here. And in the study, the most effective drugs was bromide, according to these researchers. But this is not the case in Italy, for instance. In our series, we use bromide very rarely with respect to, say, other countries in Europe. This shows how the results that we can obtain can vary. This is our patient history series. We have 2 patients. I'm afraid it's not very clear to read. 2 who were not treated and are seizure-free. And then we have patients with a variable number of drugs, from 1 to 5. And there are different drugs involved and different combinations. So this is to say that we do not have consistent data on the effectiveness of commonly used AEDs. A couple of words on styripentol, which is a drug which we use for the first time because we observed that there was some analogy between the clinical symptoms of Dravet syndrome and PCDH19 mutations. In this case, there was a good result, and the patient was seizure-free for about 3 years. Then some seizures reappeared in this patient subsequently, but we did witness significant improvement. These are the other 5 patients treated. Out of the 5, in 3, we observed a substantial improvement, over 75% of reduction in these seizures. In 1 patient, no improvement. Following the administration of styripentol, in 1 case, it was a transient improvement, which only lasted a few months. Styripentol actually deserves to be considered as a possible treatment. And this is a recent study published by the Maya research group in epilepsy, and the indication is that patients can respond to STP if we're talking about patients with this condition. Other treatment, and I would like to describe to you, we've only got some anecdotal data. We're lacking well-structured studies. This has to do with CBD use, which is used in different forms of epilepsy. This is the list of etiologies, genetic and non-genetic. In this case, this was a PCDH19 mutation patient treated with CBD. The result was good. Class B, a reduction in the frequency of seizures between 75 and 90%. Certainly, this is a treatment to be taken into consideration, even though we have as yet to obtain well-structured data in terms of effectiveness, that is. This is a topic that has just been discussed, and this obviously has to do with status epilepticus. In addition to chronic treatments, it is also necessary to consider treating acute clusters and status epilepticus. The drugs that turned out to be more effective are benzodiazepines, midazolam in particular, if in a hospital setting, whereas when the attempt is made to manage these clusters at home, other benzodiazepines are recommended, such as clobazam, for instance. This was the finding that we have already stressed. In patients with status epilepticus, there's a higher degree of risk of developing intellectual disability and autism. We don't know if these are correlated or whether the disease in that patient is more severe in its manifestations, both in terms of seizures and in terms of the cognitive behavioral evolution of the patient. When it comes to acute phase treatment, in addition to using midazolam, other effective drugs have been studied. This is a study by the Japanese group headed by Hirogashi. Phenobarbital or PHT is often used in other conditions due to other etiologies, and then methylprednisolone. And in addition to this study, Higurashi and colleagues reported good results using metyl PHT, but subsequently this data was not confirmed by other statistical studies, and we have to also bear in mind that these patients were in combination therapy with midazolam, so it's very hard to say exactly which of the drugs, in fact, provided a resolution, say, of the status epilepticus. This is a final slide on the future experimental and therapeutic possibilities. This is the only currently active clinical trial using ganaxolone, and we talked about this later. This is the Violet study. We, in fact, heard Alex Aimetti describe this study. There are a number of Italian centres that can enroll patients, and in the light of what Alex showed us, there is indeed a subpopulation of patients with lower levels of allopregnanolone, and these are the ones who are better responders, and therefore it is worth considering this as an option. It is an opportunity, certainly. Thank you.